Good morning.
Good morning.
Appreciate you guys coming in this morning. Got a nice little real manly shirts we got this year.
Oh, yeah.
I think that's your color.
That's my color. Looks good on me, don't it? Look better on you, buddy. No.
That you have to be the rebel, right?
That's right. So, hey, I hope you guys had a good time last night. We do appreciate you guys being here. We certainly appreciate all of our vendors and sponsors here. Thank you very much. We couldn't do this without you. A couple of years ago, I talked to Terry about joining in and maybe doing some of the education for you guys and starting up. And my comment was at that point in time, I want to bring in quality. I want to bring in some national level speakers. Well, guys, this guy needs no introduction. You're talking about the top of the top and the most national we can get. I'm proud to say, my friend, and I'm not going to go into a long introduction because if you don't know who George Mills is, today you will. And a lot of things that we stand up here and moan and groan and gripe about is his fault. I'm going to say that. Welcome, George Mills.
Yeah.
Thanks for that. All right. Well, good morning. What an introduction.
Only from us, right?
Yeah, that's right. That's right. So normally I just do a Joint Commission update and all that, but well, this is my second keynote, and I thought, well, geez, a keynote, that's a little different than just doing a normal update. And can you hear me okay in the back? I don't know if I'm mic'd okay. All right, so I thought what I'd do is share a little bit how I got into healthcare, and there's a purpose for me sharing that today, and it's about succession planning. So let's go back in history. Back in the 80s, when I was young, I was a carpenter. Actually, I was a steel worker first. I went to college for a year and a half. During the summer between my first and second year of college, I got a job for a summer job as an iron worker, and ended up staying there for 6 years. And I went to college just for a year and a half and quit because I was making real money. And I enjoyed what I was doing, working with my hands and that, and ended up being a Class B welder. So everything but overhead. And so life was good, except for I was working second shift, which is not a great shift, right, if you ever work that. So then I met a guy who was going to start up a small crew of carpenters and building houses and stuff. And so our first job was a 2-car garage. Our next job was a 7-bedroom mansion. And so I became a carpenter and did that for about 6 years. And towards the end of that, we started remodeling recording studios in Minneapolis. And went up from in a mansion and built a huge recording studio in this mansion. And that took us over a year. And the problem with when I have a big job like that is it takes you out of the market. And so we did that year-long job. And then we were like, well, nobody else is now calling us because they didn't know what we were doing anymore. And so we thought, well, what should we do now? So we decided, well, let's break up the company. He's 20 years older than I was, and so he was thinking about retiring. And so we started letting the guys go. And then I got a job at a college in the summer. And the arrangement was a 30-day job at the college to show leadership how they need a carpenter on staff. And I said, oh, that sounds like reasonable. And so 2 weeks into it, after I hung all these doors in the dorms from the kids bunching them out at the end of school and all that kind of stuff, I asked my boss, I said, so what do you think? You think I'm going to have a job here? Because I was going to put my name out if not. And on Friday, he said, yeah, it looks like you're a shoo-in here. And Monday, he comes up to me and says, well, I heard the dean of finance is joking about about how they got a free carpenter for 30 days. And of course, I said, what do you mean free? And he says, well, I work for a company called Service Master, and we're the ones that are funding you to show leadership here that we need you. And so through our contract, that's how we're paying you. So what's Service Master? I never heard of such a company. Well, that was a third-party management company. And so I said, well, that's fine. I have no interest in whatever you do. I'm just a carpenter. And so then I started looking for work. And then he came back to me the next day and said, well, why don't you apply for us and take my job? I said, what do you mean? Well, so that's where I got into this idea of going into management. I was like, well, I don't know. I enjoyed being a carpenter. At this point, I'm a finished carpenter and stuff. And so, long story short, I ended up getting hired with Service Master. And so they had a 6-week training period back in the 80s. Where they would take you a week at a time to different modules. So you'd spend a week in housekeeping, a week in biomed, and a week in whatever. And so my first assignment was at Abbott Northwestern Hospital, an 800-bed hospital in Minneapolis. And I remember the first day I was walking in, or I guess it was the second day, and I ended up in the morgue, and they were doing a case, and I have no idea how I got in there, but I knew that it was not a good thing to be in there after I threw up and made a fool of myself. And then 2 days after that, I was up in a geriatric unit. And I remember walking down the hall here and these old people moaning and groaning, and I was like, man, it's ripping my heart out. And I said, how could anybody work in this environment? And so I called Service Master and said, look, I met you in a school setting. Get me out of here. I want nothing to do with healthcare. Get me into schools, get me anywhere but here. I can't do this. And so he said, okay, Monday report to Des Moines, and you're going to be now in the school system. So So they got me out of that, and I was like, oh, good. So I spent the next 5 weeks in school system to learn how to run colleges and all these things as facilities directors. And then the last day of my training, I was in a room with the guy that was proctoring me, and the phone rings, and he picks it up, and he says, no, George isn't here. I was right next to him. And he says, George isn't here. And he says, okay, I'll tell him. So he hangs up. He says, that was healthcare. And they want you to interview next week. I have nothing to do with healthcare. And he says, well, let's call our boss. So we called our boss, Rich Hinklebein. And I said, Rich, what's this deal about going to healthcare? He said, they just need a body to interview, and just go and show up, and then they'll not hire you anyways. And I go, okay, that's fine. So then he says, meet the area manager next Monday at 8 o'clock at a local Perkins, a local restaurant. And so I got there about 9:30, and figuring the guy would be really ticked off, and no way he'd want me to even follow up. But he acted like it was okay. Like, oh, this is weird. And so we talk a little bit, and then he said, okay, we're going to meet me up in Wilmer, which is 2 hours straight west of here. Be there at 10 o'clock tomorrow morning. We're going to meet with the administration for your interview. So what time did I leave my house? 10 o'clock, you bet. And so he says, meet me at the outside of town. There's a small restaurant there, and I'll take you into the hospital. So I get there around noon, 12:30 or so. And he's like, okay, you're on time, wave at 1 o'clock. So who's smarter than who? So then I go, oh, man, I can still blow this. So I go into the meeting now, so now I'm in the C-suite. And so I go in to meet this guy named Jack Bear, who was the assistant administrator. Hans Stahl was out of town, he was the administrator. So anyways, I meet Jack, and so they were building a new linear accelerator vault. And this was in 84, 85. So this was a brand new technology back then. And so being I came out of construction, I kind of was, I did a quick walk around the building and saw this thing going on. So now I'm meeting with Jack Bear, and we're in his office. And he's looking at my resume. It's just construction, it's just a welder and then carpenter, and it looked pretty thin. And you fluff most of them, but you can't graduate from high school, that kind of thing. And so he looks at that, and he's pretty unimpressed. And so he slides it over the side of his desk, and he says, well, tell me about yourself. And I said, well, I'm a carpenter. And he goes, well, tell me more than that. And I just I didn't want to talk about anything. So then finally, after about 5 minutes, he closes everything up, slides it across his desk, and says, well, why are you here? And I said, I think I'm here to make the next guy look really good. He goes, okay. He says, well, we have 55 minutes to kill. He says, do you want to look at some drawings I have over here of this LINAC project? I'm like, yeah, okay, fine. Now I think the interview's over, right? Now it's just two guys talking shop. So we go over and look at the drawings, and he goes, we're talking, in this, and he goes, one of the things we're having is we think we're going to have condensation from the machine, and we're kind of worried about that. And I'm looking at, well, yeah, just put a lift station in here, and we can pipe and time it and stuff. So he's writing notes on the drawing, and then we go into electrical. And he goes, we have some concerns about this. And I said, well, I said, in recording studios, we learned that if you run your low voltage perpendicular to your high voltage, your line voltage, you won't have any harmonics in that, which is what they were concerned about, is disruption of signal. And so he's writing all these notes down and that, and he goes, at the end of it, he goes, welcome to Rice Memorial Hospital. And I'm like, what the hell happened? I'm shaking his hand and thinking, this did not go right. And so now I'm director of environmental services. I had facilities, I had operations, I had biomed, I had laundry, I had EVS. I'm a carpenter. What did I know about all this stuff? And so I was like, oh man, now what do I do? So he says, so the next day I showed up for work and moved my family up there 2 months later, and here we're living in this town called Wilmer, Minnesota, 180-bed hospital, and I'm director of facilities. Didn't even know how to spell my title. And so then now I'm in the room in my office, and they keep talking about this thing called Joint Commission. And they're getting ready for it because it's coming next year. And and all this panic. You just tell everybody's panicking about this Joint Commission. And I'm like, well, what is it? And so they said, well, here, this is the manual. Follow this. And this is the old days of the PTSM standards, Plant Technology and Safety Management, right? So he gives me the PTSM. I'm looking at it, and I'm like, well, this is a cookbook. It says do this test twice a year, do this test annually, do this. So I'm like, well, this is easy. And so I started really embracing this. All of a sudden, I found the Life Safety Code. And I was like, this is a great book. And I'm sitting here, I'm loving it. I'm reading this thing. My wife's like, what are you reading? Oh, this is great stuff. And my sons are like, Dad, you're off the deep end here. And, but I started liking this code stuff because I figured this is the way to build a right environment. And then, and I was all about the building. And we finished the linear accelerator project and doing some other stuff and had my program in place and everything. And then I remember thinking, this would be a really good job if it wasn't for one thing, those patients. Because every time we did floor finishing, I'd get in calls, right? Oh, it stinks up here. You can't do that finish. And everything we did was disruptive of patient care, and they were such a burden to me running this hospital, right? And so I'm like, those stupid patients, they're always in my way. And I go up in the nursing units, and I'd always be, this patient needs this. They need a light in their bedroom. Yeah, but it's 3 a.m. They don't care. They want the light, I'm like, This is nuts. And so I'm up against this thing called patience. Everything I want to do, I want to renovate a unit. Well, I can't give you the whole, this half of I can give you one room here and one room. This isn't working. These patients were just the bane of my existence. And then, so now I'm there about 6 or 7 months, and trying to get into some sort of cadence, And then my youngest son had to have his adenoids removed, and tonsils, and TNA, tonsils and adenoids, I think they are. And so I remember, now it's my hospital. This time it's my hospital, right? I've been there 6 months, so it's my hospital. And I remember down in the OR with him when we were taking him to go back to do surgery, and they had him in this little red radio flyer wagon. Remember those little red wagons? And John was in there in that little wagon, and he had such trust with the nurse that was taking him, and with me, his dad, being there, letting him go, and it was and it was just, and I had this epiphany moment. It was like Saul on the road to Damascus, when the light comes down, and he goes, holy smokes, and it was just the same thing where I saw everything that I did was for that little guy in that wagon. And when I saw that, this wasn't about the building, it wasn't about the Linear Accelerator project, it wasn't about all the things I was doing. It was about the little kid in the wagon. My kid, but still, as a patient. And when I saw that, my whole perspective changed. And it was like, it's all about the patient. It's not about the building, it's not about heating and cooling, it's not about managing the teams and doing all that stuff that I was pushing myself into. It was about the patient care. The one thing that I didn't want it to be about, it was all about patient care delivery. And that was the beginning of my real venture into healthcare, was when I realized that everything we do, every code that I've written, everything in 101, everything that we do is about that little kid in the wagon. And if that's where your heart is, we're going to be successful. If that's not where your heart is, then go into schools or something else, because you're not going to be, we don't want you in the business, right? So that's what I want to share with you is it's about the patient, and how you get there in your journey is the thing that you want to grab a hold to. So reflect on that. And I think the other thing I want to share with you is a lot of us are getting towards retirement in our careers. We're thinking about spending time with our grandkids and doing all those kind of things in that. Where do we get our replacements? I was a carpenter. I didn't know how to spell healthcare. I didn't want anything to do with healthcare, and I became fairly successful in healthcare. And that's going to be our next group of people that we're going to be pulling into, is anybody that can be doing anything. And it's going to have to be, we're going to have to train them in that. So Latoya, one of the things I want to talk to you about maybe is through ASHE, building some sort of a training program for people that don't know how to spell healthcare, but yet need to know what healthcare is about. They can be good managers. They can manage a 7-Eleven or a Dunkin' Donuts, be a good manager, but what do they know about healthcare? And there's things that can be taught. We can take, and the only thing we can't teach is a sense of urgency and the care for the patient. But a lot of the mechanics of what we do can be taught. And I think we can take a carpenter, we can take these people that have managed other people and train them into our world, because that's the only resources we have. I remember I had one of my hospitals at Good Sam, 400-bed hospital in Chicago, and I had a supervisor, Dave Verbeck, really strong supervisor. And I said, geez, Dave, I'm planning on moving on to somewhere else in the next year or so. Why don't I groom you for my job? And he said, I don't want your job. He said, I see you here in the morning when I get here. I see you at night when I go home. I know you're carrying a briefcase home with you at night. I know you're putting in 14-hour days pretty routinely here. He said, I don't want anything to do with that. He said, I get overtime. I put in my 8 hours. Life is good. And that's what we're up against. We're not up against when we were young and we put in those 12, 14, 16, 18-hour days. That's just what we did. Now it's an 8-hour shift. When I was with JLL, when we costed a new business, I said, put in 2 FMs, 2 facility managers, whereas it used to be 1. And that's what we're going to have to do. We're going to have to take people that don't know how to spell healthcare. We're going to have to be able to shift our schedules and our workload for them to accommodate the new culture, and also then to train them and give them that bridge between what they used to do and what do we want them to do and how to get from A to B. And maybe it's a training series or something like that we do online that we can do it like that. So we should probably talk about doing something like that. Or Terry, we talked about it last night, maybe with somebody to sponsor that. But I think that's the only way we're going to come up with true succession planning, is by being willing to take non-healthcare people, because our people that are in healthcare, they're smart enough to know that they don't want to have wear the hat, right? So it's one of the things to be thinking about is how do we plan for our succession plan, because we have to do that planning. And we should have been doing it a long time ago. But the only way we're going to get there is by thinking out of the box, and I think that's probably the best way to get there. So I wanted to share that with you. I wanted to share how did I get into this crazy business and whatnot. It's been a good ride. I've enjoyed it now that I realize why we're doing it. And everything I want to share with you is marginalized. So I was talking with a guy who's in a large hospital system, and I said, so how's it been in the facility? Because it's been, for me, It's been 9 years since I've run a facility. Okay, so it's been a while since I've done it. So we're talking back and forth. And what he used the word marginalized. And I thought, well, that's an odd word, you know, to describe what he feels and what he's doing. And I said, what do you mean by marginalized? And he says, what I mean, he says, is when I'm sitting in a budget meeting and I'm saying I need to replace my air handler because it's 60 years old and I've replaced the motor 3 times and I've done this and it's just the vibration analysis is telling me I can't keep repairing this machine, and yet it gets superseded with an MRI or some other clinical equipment. He says, I just feel like my input isn't wanted anymore because I'm always asking for things because my things are getting old and worn out. And so he felt this marginalized, and I felt like, and Latoya, we kind of talked about that a little bit too, is about how do we get, you know, money for the things that are wearing out in our buildings and that. And part of it is we just, you know, we keep fixing it. And we keep it running, you know, and it's not Star Trek where you can, you know, keep Captain Kirk happy because we're running it again, you know. At some point, these stuff's just got to fail. And you're just going to have to say, I got to replace equipment. So deferred maintenance is not the way to go. I think deferred maintenance is just putting a Band-Aid on something, and when that Band-Aid falls off, we're going to have crisis. And I've been saying for 15 years, when I've talked to, been interviewed and all these things over my career, what's my number one concern? The aging infrastructure. And it's just getting worse and worse. And as we keep, you know, replacing the components, eventually we got to get more than that. And so you got to get to that C-suite, and somehow they've got to start understanding it. And I think that the only way we're going to get there is by touring them and getting them out of the C-suite and getting them in the mechanical spaces and letting them see what's going on. I remember one time I was at Good Sam, I mentioned that hospital a little bit ago, but I was at Good Sam, and we had a couple of air handling units. One of them, a damper dropped on a shaft, and it back pressured the air handling unit and actually stretched the top of my unit to where I had a 6-inch gap if you think about it, it's 8 foot wide. And at the top in the middle is about a 6-inch gap from the top of the filter bank to where the shell had stretched from this overpressure. It's crazy. And so, so I went into the leadership and I said, I need 5 new air handlers. They're all, 45, 50 years old. And the history of those air handlers, when the building was being built, they were shipped early. And so they sat out in the Chicago parking lot, and it was a Lutheran system that was building this hospital. And after about a year of construction, they had the basements in and all that, and they ran out of money. And so everything stopped for a year. So now we have these air handlers sitting out in the lot for about a year and a half, 2 years in Chicago weather. And then they merged with a Methodist or somebody, and they continued the building got built, and they used these equipment. So now I'm in there at 40 years later, and all the floors are rotted out, and you know all the things that go bad with these things. And I go into leadership at budget time, and I said I need to replace 5 of my units, and gave him the price of that. And he goes, oh, okay. He says, we just had a budget approval for some MRIs and some other, radiology equipment. So see me next year. What kind of answer is that, right? And so then next year comes up. So then I get in there and I said, okay. I said, we're going to go on tour. So I took him and a couple of the board members on tour, and I showed him the air handlers. And I put a pipe on top of it so you could see, where the straight line was and the hump there, and the difference in that. And I said, and I explained to him. And so I got 5 air handlers that year. But it took getting him out of that C-suite, out of his office, down in the shops. And in fact, I wrote then an article, Coffee with the Crew, back several years ago when I was at Joint Commission. The point was let's get the C-suite down there where we live and let them see our mechanical space, because they're not seeing it. And I actually, the rest of that story is before I went and saw them on that second trip, we were cleaning the machines, and the floor of one of those machines was all rotted out. So I told one of my guys, I said, go down to Dietary and get one of those big pickle jars. They're about so big with the white lid. I said, get me one of those and bring it up here. And he's like, just do what I tell you. So he brings this jar, and I said, scoop that rust into this jar. And I made a label, and I said, air handler number 7, ICU, and wherever else it fed. And so I started my discussion that time with the CEO, puts that on his desk and said, we have to go down on tour. And then we talk about it. And then he saw what it was. The point is you got to get them out of their environment and get them into our environment to let them see the condition of the equipment that you're asking to be replacing. It's the only way we're going to be successful. But we got to do it to keep our buildings up. And we got to quit fixing them because Band-Aids don't work anymore. And I mean, yeah, you put a new motor on it, but what about vibration analysis? And all of a sudden you're into that, and then you're into mountings, and you're into where do you stop? So think about that, and it's marginalized. The thing that I felt from him is It's because he'd go up against that and he didn't know how to get beyond that. And I think the only way we get beyond that voice is, again, is by showing them what we're seeing every day as we're out and about in our world, let them experience that as well. And that third point I want to make before I get into the actual update is what I call normalized deviation. Normalized deviation. This was from a book, Why Hospitals Should Fly. And it's a great read. It was Ashley actually had a keynote speaker several years ago, and he spoke on it. John Nance spoke on this and several other topics. But it always rung with me, this normalized deviance. What is that? Normalized deviance is when you're driving from here to work, and the speed limit is 40, and you're going 45, right? You don't get a ticket. So after a couple weeks, you're going 45 is the new speed limit, right? And then all of a sudden you're going 48. You don't get a ticket or nothing, everything's fine. So what is your new norm? In other words, here's the norm. Well, I just moved it to here, right? And then I moved it to here. And now I'm over here somewhere and I get a speeding ticket. What happened? Because my norm was now 50 miles an hour down that 40 mile an hour street. Because it was never a problem before. And I think that's what happens with our top 10 findings. And we're going to talk about top 10 in a little bit here. Where we see these things, we see the wire on a pipe, and we see these things, and we kind of yeah, we'll get to that. Well, you don't get to it today, you don't get to it tomorrow. All of a sudden, your new norm is we're accepting that deviation. And all of a sudden, our focus is still here instead of where it started out to be here. And that happens in a lot of the code issues. It comes in with our discussions with our people. It's what is the norm, and what have we deviated to become the new norm? And we want to get back to true north, with the way we think, the way we manage, and the way we work through our equipment and our compliance with our different codes and that. I know a lot of us say, I don't have staff anymore. And that's why I'm behind on different things I'm doing. Staffing's an issue. And it's the same thing as showing the C-suite why we need more staff. These deep cuts that they're making for our staffing numbers are not helping anything, and we can't let them push us into deferred maintenance. Deferred maintenance, again, is not the solution. And we do need that staff back. So you're going to have to push for that and, quote me, quote anybody else. Ashley's got to do a better job of preaching that a little bit more to the C-suite, and we have to get into some of those venues where they live and breathe. But they need to understand our pain because that's the only way we're going to get this thing back on the. And again, lastly is we need to be thinking about, do I repair it or do I replace it? How many times do you repair it before you just say I can't fix it again? Baling wire is worn out. So anyways, so I want to share those kind of things with you to kind of get a sense of where my head is at and where I'm going with this. And to announce I have a new company. If you notice on the slide here, I'm a president of a company called the George Mills Company. How's that for a creative name, huh? All right? So consulting in that, and what my target is, maybe we could lift that up a little bit higher, Terry. Do where? Oh. You think? Oh, look at that, huh? All right, good night. Oh yeah, that's the switch. So I have a new company. My focus is in the small and rural hospitals. I think that's where I really want to help those guys. And kind of back to my roots in that. Piedmont and some of the big guys, you don't need me, right? You got your own teams and that and the great depth. But I really want to focus on the folks that can't afford to go to ASHE. And it's a stretch to be an ASHE member. I think that's really where my passion is. So if that's kind of where you're at, if you're a nursing home and want that kind of help, I think that's where I want to focus in this new business venture. And do education, like do teaching and that. So anyways, let's jump into this. And what we'll do is with questions and stuff, how do I go backwards? There. With questions, if you have a question, just ask, just raise your hand, stop me, and we'll take care of your questions as I go through it. I've got a 2 o'clock flight, so I'm going to be leaving quick after this, maybe half an hour or so I'll hang around, but I'm going to have to get on the road for that because I heard from Latoya that the traffic is horrible here. So, so I'm going to take that counsel. But so ask the questions as I go through this. I'd much rather deal with it. And also, if you ask me later, it's like, what was I talking about? So it'll keep me in context of whatever it was. So let's go that route. So most of this is on Joint Commission. If you're not Joint Commission accredited, so I'm too bad. No, a lot of this does apply to us as well, except for the first part with the safer matrix and that, which I'm going to get into first, and then, but we're going to get into the operations more of the building and that'll be more germane to what all of us do. So one of the first things is a safer matrix. You're familiar with that. The safer matrix was developed back when I was at Joint Commission still as a way to show leadership what the priorities were. Oh, by the way, I'll post this on your site so you don't have to take pictures. But it was designed as a way to tell C-suite where you landed and what the priorities are to fix, and kind of give a visual to them. That was the original intent of that. It was never meant to be this onerous thing that was going to get us in trouble or any of these kind of things, which of course it evolves into, right? So anyways, what they've done now is made some corrections to it. One of the first corrections was to put more text into it so that we know what the finding actually was. And so here's your matrix. But within the matrix now, you can't see it anywhere in the room, but each line is a description of what the finding is. So exit signs are visible and where the life safety code requirement for that is. So now we're spelling it out. They're spelling it out for us so you know exactly what the finding was in the matrix. So then when you're sorting through and saying, well, am I going to fight this finding or what is my sense of priority to it, this will really give me that for us. So I think it's a right move from the Joint Commission to help us better use the SAFER matrix for these tools. And another thing they've done is in the final report, which you're going to get within 10 days of survey, they also then extrapolate and put in there actually what the observation is with the EP that drove that finding as well. So they're making it much more of a user-friendly tool for when you're doing your post-evaluation of what you need to do and get back on track with. So I think they've really made some right steps in the right way with this. And also they've listed it in sense of priority. So the most important things are at the top of the matrix, and the least important things, I guess probably the wrong phrasing, is at the bottom of the matrix. So in other words, in the old days, the way it was last year, it just was alphabetically. So you might have an EC first before medication management, and medication management might be the real driver that's an issue, but because it's alphabetical, they did it. Now they're doing it by priority. So it could be EC first, or it could be medication management, whatever it is, goes into it. So it's not driven by the alpha, but it's driven by the event. Okay, so I think that, again, they did a real nice job with that too. And another thing they've done is they have a system overview. And you can use this two ways. You can use it within your system, so you can identify where your hospital is, and they do it by blind. So let's say we're a 10 hospital system, and we're being surveyed as a system. And you're numbered 1 through 10, random numbering, and then Terry, we're assigning you number 4, and then somebody else number 3 or whatever. So when you look at the chart, you'll know you're number 4. You don't tell anybody else if you're in the low end, or you got a lot of findings, you just tell them, yeah, I'm on the chart. But if you did really well, you're telling everybody, yeah, I'm number 4, right? So you identify where you're at, and then you can see where you're against your peers. And if you're smart, you're going to look at the guy that's really done really well and say, let's go out for lunch and figure out what they did so well, and then start pulling that back to you. But it's kind of a neat way to do this. Now, the flip side of all that is, as neat as it is, what is that going to do for us in a system, right? Why are we number 5 on that list? Or why are we number 8 on this list? What are we going to do to fix this? Well, give me new equipment and we can fix it, right? Give me more staff and we can fix this, right? So use it to your advantage. But anyways, I think it's a good thing, but it can be a hard thing for us as well. And this is, again, against the system as well. Standards of the future. So CMS. Let me talk about CMS for a few minutes in a polite way. All right, yeah, thin ice on this one. So CMS, Centers for Medicaid and Medicare Services, right? CMS, Centers for Medicaid and Medicare Services, right? 2 M's in there. But they changed their name in 2008 during the Paperwork Reduction Act. So they opted to use 1 M representing Medicaid and Medicare. Go figure, your government and action. So CMS, Centers for Medicaid and Medicare Services, they're essentially an insurance company. In other words, the government, back during the HCFA day, when it was called HCFA, Healthcare Finance Administration, it all started, the whole real story is, it started in 1964 when President Johnson was in, and he created the Social Security Act, which was part of the Health and Human Services Act, okay? And so within that, President Johnson promised the American public that they would create a way to get health care coverage through the government, and that was where Medicaid and Medicare was birthed. And it was under the Healthcare Finance Administration, or HCFA at the time. And then part of that is there was a requirement to make sure that the hospitals that are getting the funding were doing a good job. And so to do that, they had to have somebody to go out and evaluate the quality of care given. And so what they did is they looked around, they saw this group called the Joint Commission for Accreditation of Hospitals, JCAH, who had partnered with the American Medical Association, Canadian Medical Association, the AHA, American Hospital Association, and a couple other groups, and they came together because they were all doing their own independent surveys. And so let's create just a joint commission. And so in 1955, they started coming together and doing these surveys, and then in 64, 10 years later, when HCFA was now looking for somebody to do this, they saw this group called Joint Commission. They came to Joint Commission and said, look, we want to give you deemed status, which means that whoever you accredit would be deemed equivalent to as if we had been there. We mean HCFA, CMS. So that's where Joint Commission started the relationship with the government. They're not actually a government agency. They're an accrediting organization that has a contract with the government through CMS to provide accreditation services. And in 2008, DNV came in and they started doing the same thing. AAAHC does it. There's several other competitors. And also the state does it. Now, if you don't want to use any of the other accrediting agencies, you can have a state survey and pay the state to come in. The difference is the state will come in annually, supposedly, although some states don't have the staffing to do that either. But the state will come in on an annual basis and survey your building instead of you having an AO coming in. Okay, so that's how that kind of works. So then it's the relationships between it. But CMS, again, is really an insurance company that holds the purse strings to us in healthcare. What CMS would like to have happen is for the Joint Commission to be their clone rather than to be an independent agency. And so when I worked at Joint Commission, I was at Joint Commission for about 14 years, as Director of Services. All the standards you're currently living with, about 90% of them are the ones that I actually wrote in 2016. There's a couple new chapters that came in with water management, some other things that I did not have my hands on. But anyways, most everything I wrote, when I wrote them, I had the CMS K tags, which is their equivalent to an EP, alongside me, and I made sure that every EP I wrote linked back to a K tag so that there was a synergy between what CMS wanted and what Joint Commission was surveying against. And we're going to talk about that in a little bit because that's where the Joint Commission is now going to be enforced to go back to. But when I did that, and when we've done that for over the years, CMS never liked the fact that Joint Commission acted as an independent agency. They always felt that their standards were too clear and easy to understand. They wanted to make it more mystified, more governmentized, right? And so there's this real heavy forcing coming onto CMS, from CMS onto Joint Commission and DNV and so many other agencies. So what that's doing is it's forcing these agencies like Joint Commission to have a rework and relook at what they're doing with their standards and how they're really lining up more and more with what CMS is expecting to be done. And so what this is showing us is Joint Commission's modified vision for the future now is moving more and more with a base of CMS conditions of participation, or COPs. That's the base now of the Joint Commission thinking of their activities. And then beyond that is national quality and safety goals. The national patient safety goals are things that they think are really important that every survey will have a look at, okay, such as Legionella and these kind of things, and ligature risk and those kind of things. And then ultimately get into measure sets where we can compare how I did in my survey against others, which is, you saw a little bit in the SAFER matrix. They want to expand that to really being a full nationwide analysis of how we're doing in healthcare. And the Joint Commission's thinking is if we can prove that our healthcare is safe to the government and to our customers, it will help all of us deliver better patient care quality care delivery. Okay, so that's kind of where they're driving towards. But I think the key that I take out of this is the fact that everything is now based on what CMS is telling them to do. Back in the old days, Joint Commission said, this is what we're going to do. CMS, we're just doing it this way, and kind of rode through that. But things are changing, and we'll see where that lands on that, but it's forcing some big change. So part of that then is a rework of the standards of the Joint Commission, and here's kind of the sense of the project, is they want to be clear and concise and compatible to the CMS language. So you're going to see more of that as I go through this presentation. They want to consolidate their EPs. I've got a table in here that's going to show where there was like 1,500 EPs, and then we get down to like 400 EPs. And so you're going to see one EP is going to have multiple things in it rather than being multiple EPs. And so what they're doing is they're evaluating each EP for relevance and if there's a K tag that supports that requirement. So a lot of things like, for example, the 6 management plans that we currently have under Joint Commission, those are not required by any K tag or anything from CMS. So we know that next year those are gone. Now, do we just throw away all of our management plans because they're not required? Or do we keep them because they're really valuable for training staff and really framing up what we do in each one of those clinical areas, those facility areas? So my thinking is, yeah, I'm keeping them. They're not required on survey, but they still are a good management tool for me to have. So just because they're not required by Joint in this venture doesn't mean I don't have to have them. Because if I think as a manager it's valuable, have them. It's up to you.
Hey, George.
Yeah.
You know what, there's going to be a relatively close behind that, a new crosswalk document I usually buy that book just to, you know.
Yeah, Terry, so let me tell you where we're at as far as getting the answers. This comes up a little bit later, I'll just do it now. Is I take Herman and McKenzie out for lunch every other week. And every other week, the first thing I say is, do you have the standards available yet? And I've gotten a glimpse at them, but I cannot share them. And that's just because I hired Herman years ago and he owes me, right? But so they're not out yet, and what they are is they are developed. They have been reviewed by CMS. They made some edits to them, given them back to them. But Joint Commission's leadership is holding them in abeyance right now, and I don't know why they're holding them. It's kind of where, I think this is where Herman feels like he's marginalized, because it's like, we're ready to go, why can't we? And leadership's just holding them back. So we don't have a date, other than they're trying to figure out getting them out to us by January 1st for next year. And I told Herman, he asked me, he said, how do I, I'm really sharing way too much. Don't film this. What Herman asked me is what do I tell leadership as far as how long it's going to take to implement a whole new set of standard requirements? I told him it would give us a year. And he says it's going to take a year because the first 6 months is going to be the culture shock of just what do we got to do differently and figuring them out, and then crosswalking them into what do we have to do. And the next 6 months is actually doing it to where you can evaluate me then a year later after I start them. So he went back to leadership with that, and they gave him, well, maybe 9 months. And then, so they're pushing it, they're squeezing it down. Now we're already into March. And they still want to go out with these in January 1st of next year. So right now we're at the 9 month if they relist them tomorrow. And, you know, as of last Friday when we talked again, you know, they're still not ready to go out. So, and as far as when the crosswalk will come, that'll come, it's developed. You know, he's got it already. It's just a matter of it's being held by leadership, not ready to be released yet. And he's not even sure why. So, not a good answer, but it's the truth right now. Yeah. So, what I'm thinking is if this thing's not out by April, May, then it's going to be a second quarter next year. All of a sudden it'll be released for March, but they don't really like to do. So that means maybe they'll push it back into June or July, which is their mid-cycle, which is normally when they changes is January and July. So then it puts us into July of next year to give us more room to do it. So I just don't, you know, like I said, every other week I keep pushing myself. I'm in Georgia, I got to have an answer. Well, that didn't even work. So no change to the following. Patient care and organizational functions, they're not touching any of that. There's still going to be standards and there's going to be EPs in the new chapters that's going to be coming out for us. The outlines will still identify that it'll be the new language of a PE, physical environment standards, rather than EC or LS. They're combining those two chapters into one new physical environment chapter, so it'll be PE, whatever, okay? For the numbering schema, it'll still be the 6-digit number with the, you know, three sets of 2. That will still be in their numbering schema, and it'll tie back into the SAFER matrix as it currently is. So in the big picture of Joint Commission, they're just going to have a new chapter called Physical Environment, and the EC and Life Safety chapters are gone. In the micro world, our world, this new Physical Environment chapter will pick up both Life Safety and EC within it. Okay, so ILSM documentation, you still have to have that, so there's no change to that. You know, what do we do when we have a disruption and all that? Because that's driven by 101. Y'all are aware if your fire alarm system goes down or sprinkler system goes down, you have to respond within certain hours and all that. So that's all still staying. And the survey process, the interview, document, and observation, all of that will still happen the same way. So structurally, Joint Commission can roll this out without any huge impact to us as far as how they're doing their survey. It's just going to get back to the language that they're going to be using in that, and it's going to be interesting. So, no more environmental care, replace new. Okay, I talked about that. COPs are in alignment. So the conditions of participation. So again, in the CMS world, they have what's called conditions of participation. Okay, COPs, and that's the 482, 41, A2, or those kind of numbers that you see in the reports and all that. Those then drive a section in the Code of Federal Register where they're listed as being law. Okay, so these are all regulation numbering. When you see a 482, 41B, then to support those, they have two things. They have A tags and they have K tags. Okay, the A tags is the administrative tags, and you'll see, for example, Terry, what I'll do is I'll send you this document. It's only 3 pages, where it gives you the COP, and then I've given you a crosswalk to the A tag that goes with that. So for example, when we're talking about the life safety chapter, we currently have the life safety chapter. That's all being driven by 48241 B11, okay? And you'll see that on an example slide I have. And that says the hospital must meet all the applicable codes of 101. When they use the word all, that means what? All. And that's where CMS never liked Joint Commission, because Joint Commission, we pick and chose a lot of things that we felt were important to comply with, knowing that there's other things that we're not really grabbing at this time. They push us, and that's where the Joint Commission, when we created the wildcard EPs, those ones where it's anything else, that's in chapters 18, 19, or whatever of the Life Safety Code, that's why we had to do it, because of the word all here. So when you think of CMS, they're not thinking of like us, where we think what is realistic for us to manage. They think, oh no, here, adopt this book. You know, take 101 and go with it, and that's their thinking. That's where they would like us to get. So anyway, so you have the COP, and then you have the A tags, and then the K tags. So the K tags are not referenced in the A tags or the COP directly. They are a numbering. They're a second document that CMS has created for a survey against. So you would think, oh, that's more closer to an EP. Well, not really. The EPs, when we wrote those, we really wanted the EP to be more of a recipe for success for us. The K tags are not written like that. They'll say things like, for generators, they'll say comply with NFPA 110. Okay, well, what does that mean, right? Well, that's where the weekly comes from. That's where the fuel quality comes from. That's where the 96 hours comes from. All that, because that's in 110, right? So they'll give us these one-line sentences that then says, oh, good luck, right? So the EC and Life chapter and EC and Life Safety chapters are gone. In hospice and ambulatory surgical centers, they're not going to be affected by this change immediately. That'll be a phase 2 rollout. They're really looking at hospitals and critical access hospitals right now with the new physical environment chapter. And they look to the CMS SOM is the state operations manual. That's where the A tags are housed, and that's what I'll send you. It's a 3-page document. And the interpretive guidelines, you would think, oh, they have interpretive guidelines, right? But when you look at interpretive guidelines under the A tags, about 60% of them say pending. So what does that do for you? Let's see, again in the back, you won't be able to see this, but this will be a handout that I'll be giving Terry to have for you. So this is an example of the A tags, where you can see the 482, 41, A1, 2, or whatever, and that gives us as much guidance as the A tags will give us. So when you crosswalk, you have to crosswalk the EC and LS chapter to the A tags and to the K tags. And then taking those, and that's where you have to figure out, okay, now of that information, how do I get a new physical environment requirement? Okay, so Latoya.
So in 2026, if everything goes perfect.
If everything goes the way they want.
Yes, when your commission is coming in and they see the reference documentation on your documentation, like for instance, you have your ECLS, whatever, and you have your NFPA, whatever other regulatory requirement on your actual documentation, is expectations going to move to EP, like they're going to say this is not acceptable, it should be EP, whatever.
Yeah, in the document that I told Herman, I says that we're going to have to convert our CMMSs, because a lot of us have our CMMSs set up to where, you know, work orders and that are driven by the EC or the life safety numbers. You know, your consultant reports that you're getting, right? You know, we give them to you as, these are your EC and your LS findings and stuff, and then you work off of those. And when I asked for that year, it's because we're going to have to go from that thinking, that culture, to a new physical environment culture. And he's got to give us a robust crosswalk to get me from A to B, so I can start doing that. And then the software is going to take a major hit on that, you know, so. Well, that's the question, okay. You know, and that's what I told him. I says, in the Joint Commission's world, they've always given a 6 months lead time before when a standard is introduced to be required. 6 months is not enough time to go from 2 chapters to one new chapter. So there's going to have to be some sort of a leniency the first 6 months going out. I can't guarantee that, so I can't speak for Joint Commission, but I'm sure there's going to be something to where if we can crosswalk for them and say, you know, these are our minutes from last year. You can see that, you know, we dealt with things in the EC world, which are now converted to PE, but that came over from here, so we're still working on it under that until we close it out. They're going to have to see that there's a process there going towards that. So that didn't really give you much of an answer, did it? I could be a politician. But, you know, well, it's going to be, yeah.
That's why I asked him how quick the crosswalk was coming out.
So
Yeah. And
So the joint, now, Joint
somebody will
Commission,
sell the crosswalk.
so Joint Commission surveyors were trained in January on the new chapter. And I said, well, how did you train that? And he said, well, we gave them examples of where it's going to go because, again, it's not been approved yet. So they were just giving high-level examples to them, and again, that would be the discussion of how do we survey against the new expectations against the old expectations. You know, think of it this way: when water management came out, you know, the new 4 EPs in the chapter, that came out. We had a lead time. We knew it was coming. When it first came out, that they were pretty soft on how they surveyed us. You know, what are you doing for water management? Do you have a team together? Does it include leadership and blah blah blah, and walk you through it? And they're pretty lenient at first. Now, when they're out there, they're expecting, you know, hard information because it's been out 4 years. You know, I think it'll be the same kind of discussion where, all right, you know, we're looking for this, and they're not going to be looking for management plans anymore. So, you know, those kind of things, we know what they're not going to look for, sort of. So, anyways, it's going to be a moving target for all of us, and that's why I keep pinging on us. When are we at it? So again, what they want to get is 3 EPs for each condition of participation as a limit. Other things that are legacy that are not going to be gone, but will still be there even though they're not driven by CMS, is the workplace violence standards. They're going to stay, and I think that's really important because workplace violence standards, if you think about it, there's 4 different EPs that deal with workplace violence. 2 of them are in the EC chapter, you know, the annual training, and then when it comes again in chapter 4 of the EC chapter where it talks about a process to evaluate a safe work environment. And then there's 1 in leadership and 1 in HR as well. So when you ever have 4 EPs with a topic that cascades, you know that that's going to be an important thing to be looked at in surveys. So workplace violence is not moving. And water management standards, even though there's not a K-tag driving water management, those 4 EPs are going to stay in some form under the new physical environment chapter as well. So we know those 2 are staying. Management plans, as I mentioned, are gone. And because the management plans are gone, what happens then to the annual assessment of the effectiveness of your EC committee? It's gone. In fact, do you need to have an EC committee anymore? Not really, because you're not driving it by management plans and you're not doing the assessments that we do in chapter 4. In fact, I asked Herman this question. I said, what are we doing with the whole quality part of our business? You know, you get into chapter 4 of the EC chapter where it talks about monitoring and then evaluating it and then putting something in place to fix it and get better with it. He said, yeah, he said, CMS would consider that to be part of QAPI. So in the clinical world, you have QAPI, which is Quality Assessment Patient Information, I believe. And what that is it's the clinical side of how they manage clinical care in a quality venue. And Herman said that will then translate into what we're doing in our world. So the QAPI analysis will be part of what clinical does, and somehow we'll have to interface with what that does. But again, I got nothing to hang my hat on other than conversation at lunch on the quality side. I think I cut you off where you were going to go.
The only thing I was gonna say, in off the standpoint, you know, safety committee still sort of has to be around because it's still an OSHA requirement as far as I know.
Right.
OSHA still requires you gotta have some type of safety committee, so you still gonna have to have something from that standpoint, and that information still, I take my information in my facility into quality already.
Good.
Everything. I report my annual reports to the quality board this next week.
Right, and that makes sense. That makes sense that you're doing that. And also, you know, in the clinical side, you have patient safety as a leadership requirement, which is always butted up against the EC safety committee. And we've always dotted lined them. So my hunch is, yeah, it might be gone from here in our world, but it's still going to be a requirement in leadership. So that'll then trickle over, and so we'll still be wearing those hats. And to your point, you know, that communication back to quality is still going to have to be happening for us. So, all right. Again, the language of the COPs, the language is the hospital must be constructed, arranged, maintained, and ensure safety of the patient. I mean, it's so high level. How do I build a building against this? How do I manage against this? And you really can't. And then because of that, you go to their SOM. Again, and a lot of things in the SOM, State Operations Manual, they say that it's pending information. They can't give us guidance on it. So again, we're back to what do I do? What it's going to be, I think, in my world, as I move into consulting, it's going to be, I'm still going to have the EC and life safety requirements in my back pocket. I'm going to cross-talk them to the PE chapter, and that's what I'm going to be looking for, all the things that are in the EC chapter that we've been doing for testing of EC 235 for all my systems, because I don't have clear definition on any of that, but yet it's required because the code requires it. So I'm still going to be living to Latoya's point, I'll be living to my EC world in the new PE world nomenclature. So it's gonna be nuts. All right, and this is a table I'm building to help my clients if I have any, and where I'm taking the current EC requirement, so 235, and then I'm putting the K tag that associates with the EC. So for example, monthly fire test of your extinguishers, K355, the actual language is, portable fire extinguishers are selected, installed, inspected, and maintained in accordance with NFPA 10. So what's that gonna force you to do? It's gonna be buying a $2,500 set of codes from NFPA, right? And you're gonna buy 2012, which I hope are still available because that's the code that they're using. And then in 2 years when they go to 20 or whatever they go to, you're gonna be reinvesting in another set. Or you're gonna do the subscription server with NFPA, and I'm not making, here I'm doing a sales pitch for NFPA. I don't get any money for that. Anyways, you're gonna be doing some sort of subscription service so that you can look and see what NFPA 10 does say about maintaining your fire extinguishers. Or you're gonna have in your back pocket EC 235 and the 3 EPs that talk about fire extinguishers and say, oh, here's my information right here. Right? So anyways, and then there's the A tag, A724, that gets you to the COP D2. So that's what I'm building as a table. Is that gonna help? I don't know. It's the best I can come up with so far.
Well, if anything, then you can print and produce the crosswalk.
There you go.
There you go.
Well, I'm in Maryland in 2 weeks, and I'm doing a 6-hour class, and this is what I'm going to be going over with them. So I got it all built. That's what I was working on last night. It was a final run through.
You got a publisher door.
That's good. You and I should talk. Anyway, so that's where I think we're going to land is just kind of a crosswalk, and get us there, and we'll see what they do. And then in the K tag itself, here's what the K tags look like, and this is in form 2786R, and you can download this from CMS. Just go to CMS, what you do is just go into Google, type in 2687R, and it's going to give you a list of them, and one of them in there is printable and editable. Is that the right word? So you're not eating it, but you can change it. All right, and anyways, that'll get you the same list, so that's where it starts to come from. But again, what I want you to see is how benign this language is. This is not language that I could manage a building against. And yet this is what CMS is forcing us into. And this is your COP language for D2, which is facility supplies and equipment must be maintained to ensure acceptable level of safety and quality. And about 90 of the EPs of the physical environment chapter give that language. And so that's the language we use for our testing of our equipment, anything related to safety. All of that is in that one sentence. So it's going to be a nightmare. Anyway, another example. I said nightmare, yeah. You heard me right. And that's the thing is, I promise you as a consultant, I will not be the consultant that comes in and gives you a list of what you got to fix and then leave you. I'm about partnerships. And so that's why I plan on having a lot of clients, because I want to work with you to get stuff right so that when you're, at the end of the day, you and I are both good with where you're at and where your head is at with what's going on. But it's going to have to be that way. We're going to need to be holding hands with each other and get stuff through. Survey process, again, no changes. You're still going to have the daily briefing. You have the facility orientation. You're going to have to give them drawings. You're going to have the drawings be current and accurate. You're going to do your building tour. They're going to be above ceilings, and they're going to do all the things they normally have done. So you're not going to see structurally changes to the survey process. It's really just the content of the chapter that you're going to see change to. Staff competency, this is now in effect, right? And what they're looking at are two things. At the HR review, which is done by leadership, your nurse or your doc during the survey will be in HR, and they're going to be asking about competency of different directors, including facilities. So you want to make sure that your job description is true and accurate, and it's in HR, and they have it available, and that when you do your annual evaluation or however they manage you as a director, that's showing up that you're competent for doing what you're supposed to be doing. If you have a license, is it current and being maintained? Anything like that that's germane to the proof that you are competent to do your job. And then at the facility level, the life safety code surveyor is going to be asking you about competency of staff. And of course, the obvious ones are fire alarm. You got NISAT certification for whoever's maintaining your fire alarm system, whether in-house or contract. They don't care, but whoever's maintaining the system has got to be qualified. Same thing with medical gases and fire doors. There's not a license certificate required. You can do it in-house, but if I'm doing fire doors and that in-house, I have to be able to show why my carpenter that's doing this work is qualified. Well, he's the guy that installs them. Well, that's a pretty good reason for saying he's competent, right? And but you want to have in his job description, his or her job description, why they're competent and things that you look for, and then do some sort of an annual evaluation of their competency. You know, our doors are all being maintained and blah, 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 that kind of thing, whatever it is. And then other things, so if you're required to have a licensed boiler operator, then you need to have proof that your boiler operators are licensed for high pressure, low pressure, whatever your license requirements are. So those are the obvious ones. If you have any other folks that are certified, either they've gone through the GASHE, EVS, where they go through the class about how to be an EVS person, that's a great way to have to show that you have certification for that. You might even just run your supervisors through the class so you can show, again, a level of competency for how we maintain our buildings for that, for infection control issues. And same thing with our staff, in maintenance and that. How do we make sure our people are competent? And what are we taking them to get them from A to B, from being a carpenter to being a mechanic? All right? Is there any questions on this? Yeah, in the back.
As far as having a licensed boiler operator, I mean, does that include just your daily operations of your boiler, or just any work that's being done on your boiler? Can we use a third-party contractor for that?
So I'm from Minnesota. If I'm running high pressure steam, I've got 24/7 in my power plant. And those people that are running my boilers have all got the class 1 boiler license. And it's all hanging up on the shop office. I don't know what your requirements are here, so whatever your state requirements are, that's what you'd have to be able to show them. If it's not required, then don't worry about it. But what I would do is make sure that the guys that are running your stuff are competent as far as what do I expect them to be able to do. They know that they're not going to blow down the boiler to the point where they're exposing tubes and blowing up the place, and that kind of stuff. So you want to show, how do we know that my team is competent? Through job descriptions, through your evaluations of your staff and that thing. So they're really following what it is that your program says they should be doing. And that's true whether it's a boiler operator or somebody else maintaining kitchen equipment or whatever it is. They know what they're doing. Okay. That reminds me of an old story. So we had a guy who didn't know what he was doing, but his job description was as a mechanic, right? My first hospital. And so we had a third-party guy come in to tune our boilers. And in the old days, the old analog boilers, you could skip the purge cycle and light off boilers. To check the timing of everything and check the flame in that, so you could skip them. So this Cliff was working on a Saturday, and the boiler didn't light off. This was because the guy had been here earlier in the week and was tuning the boiler. You always have problems 3 or 4 days after that. So Cliff was in, and he's our guy that was marginal, and the boiler didn't light off. So he goes and he skips the purge cycle to light it off again. It hits fire, and shook the building. And so gave me grounds to terminate, and it was either terminate or reduce his requirements. So I put him down to a helper and froze his salary until such day that salary came up to it. But crazy. And then the union wanted to grieve me for that because I demoted the guy, and I said, "You want me to fire him?" Which is my alternative. And they said, "Well, you should fire him because he's not doing the job." So, go figure. Anyways, yeah, I didn't fire him.
Question. So we formed a tiered level of mechanics, and to reach a level 3 mechanic where I am, you have to have a certification that makes you subject matter expert. So case in point, door inspection. I've got if mechanic takes the door inspection, becomes qualified to inspect the doors and do the PM, he gets level 3 certification.
Perfect.
That
That's wonderful, yeah. And that's what I would do is in my opening conference, I would say, this is how we set ourselves up structurally. And then right away they're in, okay, so you've got the handle on the competency of your staff. And you have goals and targets. I think that's great. Absolutely, absolutely great. All right, survey window, we went from 18 months to 6 months. You're aware of that? So what that means is your three-year cycle for survey. At 18 months, that's when we normally start panicking, saying, oh man, now we got to get serious again. Well, now it's down to 6 months. So now instead of having a year and a half to get ready for survey, you're going to probably wait till the last 6 months and then really panic, and then consultants will love you. So just be aware that it's gone down to a 6-month lead time now before survey. Be smarter than that and just keep yourself always compliant. Immediate threat to health and safety. I always like to remind you of these 4 bullets of things that you're going to get in trouble with. And you do not want to have an immediate threat to health and safety, right? Because then the world, it goes crazy. You don't want that. But it's air pressure relationships in critical spaces can get you there. Fire alarm system failure can get you there. Not using your infection control risk assessment for construction can get you there. And ILSMs not having those active and in place. And an unusual high number of penetrations in rated barriers can get you there. So be aware of those things as far as what's going on. And those 4 there actually were ITLs last year. So, all right, let's see. Got one clarification I want to throw out to you with your ORs. So in our ORs, we have certain doctors that want the temperature lowered than the normal range, right? And normally we know Dr. Jones is in tomorrow, so tonight you start lowering the room temp down, so when he gets here tomorrow morning at 7 to start surgeries, it's at 63 degrees or whatever they want it to be at, right? Well, you can do that, but what you can't do is just do it as a blanket waiver. It has to be a case by case. So now Dr. Jones has got to say, tomorrow I'm doing 5 cases, one for A, B, C, D, and E patients, and I need the room at 63 degrees for each one, and then sign off for each room or each case that he wants it at that temperature. All right, so in other words, you can't just do a blanket waiver, oh, Dr. Jones is coming. He has to initiate it through a process that you will develop as far as what do they want in those ORs. Does that make sense to you? And the answer is no, it makes no sense at all, but that's the way it goes. And that's because the language in the annex to the table that gives us the requirements, it says surgeons or surgical procedures may require room temperature ventilation, and the Joint Commission believes it's a single event language of the annex, or the appendix rather. And so that's why they are forcing us to go into a case-by-case document.
Question for we had to do this a couple of years ago, and we very specifically looked at that verbiage, and I'll read it. Surgeons or surgical procedures may require.
Plural, I know.
So in my world, if they are wearing a lead apron, I can lower the temperature. But now you're saying it would be case by case.
Case by case.
So every time, I can't do it just because they're wearing a lead apron.
Right.
I'm glad I'm D&D.
Yes, well, and that'll catch up to them too sometime. Yeah, it is. It's just, and I had the same argument with Herman when he said this. He and I argued about several of these things,
That's
but
gonna be a major deal.
it is a major deal because clinical is what doctor is going to want to do that, and then we don't want it in their charts. We don't want it necessarily in the patient chart that you lower the room temperature. So it's going to have to be some sort of an autonomous document that they're going to sign off on the day before or whatever, so that you can then do that for that room. So, make sense? No. Do you have to do it? Yes. All right. Some survey process issues. See it, cite it. Back when I was young, you could at least negotiate. Those days, that ship has sailed long ago. And this is being driven 100% by CMS. Okay. Document review. There's a list on the Joint Commission website. You can download that list of what they're looking for. And I keep an eye on that, looking for the new PE chapter to pop up on there. It hasn't. So documentation. The review, they allow 4 hours for your document review, but they usually do it in about an hour, hour and a half. So that gives them some extra time then to get up on the floors and do a little additional walking. Electronic records are fine, but if you're using electronic records, you got to make sure you know how to run the equipment, the software. Because when you start fumbling, surveyors can get frustrated and say, screw this, give me a hard copy. Well, I don't have a hard copy, this is all I got, and then all of a sudden you're into another world of hurt. So it's okay to do it, but you run the boat and you make sure you know how to be fluent through it. So when they say, can you back up to that one so I can see the 3rd month of the year or last year, you know how to get to that date and that document that they'd be looking for. It's okay to do it, just know how to use it. Yeah.
George, on the back of temperatures in surgery.
Okay.
Back in the old days, and I think you and I were there then, the whole point, one of the major points was anesthesia. That if you get the temperatures too low, the patient's going to shiver, causing more anesthetic to be used. That was one of the major driving forces for that temperature in surgery. On top of it, adding, making sure you're controlling your humidity in the room, which is a thing for us. Would it not be a better way to measure that is to measure patient temperature during surgery as opposed to the temperature of the room? And then also making sure that your humidities are in line, as opposed to just establishing the fact, like Terry was talking about, there's somebody in that room that's got a gown on, or lead apron on, and that room needs to be cooler. And the key points is to measure the patient's temperature to make sure that they're in range, and measure the humidity.
Yeah, it's a couple different issues you're talking about. Is one is what do we control? That's the room environment. The other is the cooling bed that the patient's in and on, and their core temperature and those kind of things. There's studies being done that bringing the room down isn't the effective way to deal with it. The real way to do it is by the cooling beds and to bring the patient body temperature down and keep it localized, but not be dependent. And the second thing you mentioned is humidity. And I've always thought that ASHE should really be fighting for 65 being the bottom limit. Because you get 65 and above, you don't have the dew point problem. You get below 65, now you're getting moisture condensing in your room. And you have another world of hurt. So I think that we should have codified 65 as that bottom number and just worked with that in our ORs as far as a range that we should have worked with. But I think you're right as far as, body core is really the big thing. But we also have surgeons, to Terry's point, that are gowning for whatever reasons, and they're hot and they want the room down because that's what they're doing. And they're in for 5 hours or whatever, and they want that room to where they want to work. So, is it the best way to do is body core? Yeah, probably. But I'm not, being non-clinical, and from what I understand, is body core is not good for the patient anyways. We should really have other alternatives. But right now we deal with the cards we're dealt with, right? And that's the room environment, and that's what I'm talking about today. So bottom line is that doc has still got to say, I need the room at this temperature for these 5 cases in each one individual. So, all right, what else? And by the way, let's see here. Let me go back to documents. So they give you a pretty good list here: life safety drawings, written fire response plan, those things that you have to have readily available. So my advice to you is, even if you have these things electronic, I like to have a single binder that I call a survey binder, and I do a rolling 12 months on that. So I roll out, so I do a test. The first page of that test comes into the binder until the next one comes in, and that one goes with the rest of the binders, or however I got it, or electronic, however I got it. But somewhere I have a tangible in my hands, so when they come in, I can hand it to the surveyor, so you can start here, and we go electronic for anything deeper than this. And then if they go through it and they say, I'm curious about this, we go, okay, well, here it is, and then bang, it is. So that's personally how I like to get ready for survey, but you can do however you want. But, and that would be something with your drawings, and fire response plan can be tucked into that same single-use binder for them to be able to manage through. So up to you, how do you want to do it, if that's what my recommendation is. Infection control issues that roll into our world, dusty HVAC vents and non-cleanable counter and wall surfaces. What they use that for is when I have a door and it's been chipped, they say that's a non-cleanable surface. It doesn't mean that we bought these kind of tabletops. It means that we have damage to our surfaces that can't be cleaned. So let's see. And some of the things that I don't agree with are GFI outlets for pop machines, soda machines. Why? But anyways, they found some obscure code that requires that ice bin in the kitchen because they say that it's a water source within 6 feet. So I don't know. But these are things that surveyors have been taught to look for. Kitchen issues. Where do fires start in hospitals? Kitchens, right? They're number one. So the Joint Commission, actually, I couldn't find it the other day when I looked for it, but I understand they have a kitchen checklist that the surveyors are using in the kitchen environment. You might want to look for that. One of the things that I see happening is the grease pot. When the suppression system is here, they pull it out to clean. They clean behind it, and they slide it back here. And it's no longer directly underneath the suppression device. So easy solutions: mark the floor, tell them, put the feet in these little cups that I have here on the floor, or whatever. So, and the other one is a K-type extinguisher. I'm not talking about the Ansel system, but the individual use K-type extinguisher. That's blocked by carts and stuff like that. So you want to make sure that that's available to staff at any time too. And then next 15 minutes or so, we'll talk about the top 10 findings for EC and life safety to kind of give you a feeling of what's been going on. About 18, almost 19% of the hospitals have at least one requirement for improvement in the EC or life safety chapters. 50%, more than half the hospitals, have at least one condition level deficiency. Now, my goal has always been, I can live with a standard level deficiency. Those things happen, but I don't want to have any condition level deficiencies. The condition level gets you a follow-up visit. The standard level does not. So I can live with standard levels, but my goal is always, let's be careful of the condition level stuff. And certain EPs will drive a condition level. So one that has been taken away from us that we've always enjoyed was the one in the ORs. So last year they took away the one where if you have an OR deficiency in your ventilation system, we used to be able to fix it while they're on site, and then they could review it and then stand you down to standard level. they're not able to stand it down anymore. CMS has said, no, once you write it as condition level, it has to stay at condition level for the survey. So we've lost that, and that was something I fought really hard for. And again, if the boy's not there with his finger in the dike, these things happen, right? So anyways, let's look at these. I think I have a deeper look here. All right, I do. So we're gonna look at the top 7 for EC first. Normalized deviance, remember when we talked about that? Keep that in the back of your mind as we talk about these, because these are the same lists I had back when I was Joint Commission. I left there in 17. The reason I left the Joint Commission is because this list never changed. The only thing that changed is what order they were in. We'd be talking about wires on pipe, wires on pipe, wires on pipe, and all of a sudden that was number 1, and then it would drop down, the next year it would be number 7, because we talked about it all the time. But then instead of that, it would be something else benign like furnishings with a rip in it. So these things just jockey up and down. They're the same stupid findings. But anyways, so number 1 is interior space to meet the need of the patient population. Stained or wrong ceiling tiles or ceiling tiles not in there, not sitting in the grid. Just stupid things, right? And the solution to this is what? It's rounding. It's getting out of your office and walking around. It's having, you know, I personally am a huge fan of zone maintenance. And one of the reasons I left Joint Commission was to see if I could figure out ways to be successful with this list. The only way to be successful with this list is zone maintenance, where you have an individual assigned to a certain number of square feet. And the way I used to do it was for general care areas, they had 100,000 square feet. Before I say this out loud, I have to think. You know what, I'll get you a list. Because I had ranges that were reasonable, like in the public spaces was I think 125,000 square feet. General care unit would be 100. Critical care areas, ICUs, ORs, that was down to like 50,000 square feet. Kind of based on how intense is the area that I'm covering. And so I had it figured out like that. And then what it would be is the zone mechanic would start out his or her day, with a list of the things that they want to be checking in their area. And so they had 2 choices. Either they would begin at one end of their unit and be marching down at doing all 10 items. Maybe they're only going to get 30 feet, but they got all 10 items fixed. And tomorrow they come in and they start where they left off, and they go another 30 feet and got all the 10 items fixed. So 2 months from now, they got the whole thing right. And the next time they go through, it goes a lot faster because they fixed those major things that were done, and now they're tuning them up, right? Or the guy can go with just doors and just do all his doors. And then the next thing on the list is wires on pipe. So he's going to spend the next 3 months doing wires on pipe or whatever. So they're, in other words, they have a structure to what they're looking at based on the top 10 until we get those running. And once we get those running, then we get into maintenance. So it's really zone inspection at first and then zone maintenance when you've gone through it at least once, getting these things fixed. And it's the only way that I've been successful with the hospitals I ran when I was with JLL. To be successful are the ones that would listen to me and let us do zone maintenance. And we actually had it figured out how to do, like at Kindred hospitals where there's only 1 or 2 guys, we were still able to be effective with zone maintenance. We would say if you're doing zone maintenance for the first 2 hours of the day, and we want you to go this far, and then the rest of the day you're doing your scrambling like you normally do because it's only you, and that kind of thing. But we have had it work, so zone maintenance is the only way you're going to be successful with things that are like stained ceiling tiles and things that you see that you can fix and get ahead of. Make sense? So I saw a hand go up somewhere. Yeah.
I just can't make it work. And I'm gonna tell you why. Because the main guys that's fixing everything, he can't go through a floor ambassador because he's fixing his floor, that other guy floor that can't fix nothing, and that other guy floor that can't fix nothing. They can't go fix nothing on his floor when it tears up because, you see what I'm saying?
I do.
And we're at a place to where we just putting out fires all day, every day.
Yeah. Let me give you a solution. So I don't know if you heard in the front and the back here, but what he's saying essentially was zone mechanic can't be all things to all things in his unit. He just can't. And so, and he can't be a specialist to do all things and all things in the unit as well. So what we did is we'd had 2 tiers. We had the zone mechanic, kind of like your ambassador, that's just doing the high level stuff. He's doing stuff he can fix easy. But if he's got a toilet that's beyond an hour, he's calling downstairs and now I'm getting a plumber up there. The plumber's taking over. And so zone mate, he's out of there. Because all he's doing, he or she's doing is kind of the light level stuff that a guy can do on a regular basis and that. But I have my experts, my professionals, that can get up there and do a toilet, or they can get up there and do this or that. So we kind of split it to where the heavy lift is done by the people that can do the heavy lift. And that way it gives me a chance to use you were talking about 3 tiers. The tier 1 guy can go through and can identify stuff. And right away he's saying, this door it's not closing right. Well, it's more than just a hinge. We're going to be putting the shims in there. It's out of his purview. He's going to calm down. We're getting a carpenter up there tomorrow or the next day or whatever. Start a work ticket. So that's kind of how it works. So I think it solves the two issues. One is I'm still making my way through, but I'm still fixing the stuff that the guy just can't get to because it's too much intense. I don't want him spending more than 2 hours on any one thing. And that's just an arbitrary number based on what I used to do. And you might say 15 minutes is too long. I'm calling downstairs or whatever, but the key then is you have a downstairs to call to. And it might be with Kindred hospitals, we use, a lot of times it would be a third party. They get into something that they can't fix right away, we're calling in, Tim's Plumbing Company.
Right.
Or something like that, so. But you can, and that's how we've been able to figure out how to make this thing work where, yeah, we can use, and a tier 1 guy, they're learning. They're learning a lot of stuff as they're going through and seeing, things they've never seen before. And then eventually they can become a tier 2 and get out of that. Move on. So does that make sense? Okay. All right, let's see what else on our list. Oops, I think I went forward. Number 2 is hospital labels, utility systems for partial and complete. What this is the fire alarm panel, the breaker in the fire alarm panel, or in your electrical panel, the breaker that services your fire alarm panel is not identified. It's got to be clearly identified, and they like it to be red. And you can buy red breakers. Granger sells them and all that. Or you can buy a $2 bottle of fingernail polish and paint the breaker red. I don't care, just so it's clearly identified. But the other thing that you have to do is, in that panel, identify what it's feeding and where that is. This is feeding the fire alarm panel in the supervisor's office. I go in the supervisor's office. Is there somewhere that says this panel is being fed from electrical panel 72 that's over in such and such location? So do I have a close the loop as far as where it is and what it's feeding and where it's feeding been fed from? So does that make sense? And it's got to be clearly identified. Yeah?
Does that apply to the industrial agreements?
Yeah, it does. Yes. Anything related to the fire alarm system, anything that's being powered by it, I would key to that. Yeah. And again, the solution's so cheap, right? Number 3, hospital IT inspection, testing, and maintaining a non-high risk equipment isn't hitting your 100%. And what this is, the finding has been open junction boxes above the ceiling, and that just goes back to training our staff, right? Don't think you're going to go back after lunch and get to it, because you never get back to it after lunch. And that's why they don't get closed in the first place. Oh, I'll be back in a bit. You never get back in a bit, right? And next thing you know, you forgot about it tomorrow or the next day, right? So teach your people, button it up, then go eat lunch, and unbutton it when you come back. Just the way it's going to have to be, or don't start it until you get back from lunch or whatever. And then exceeding your inspection, testing, and maintaining schedules for non-health, non-critical equipment. That's still a 100% requirement. So if you have it on your inventory, that requirement is for 100% of that equipment, right? So make sure you're getting there. Minimizing risk associated with selecting and handling chemicals, eye wash stations. So eye wash stations, just real quickly. Jeez. On eye wash stations is don't call them eye wash stations unless you have to call them an eye wash station. Call them a first aid station. So this is the deal. About 15 years ago, when bloodborne pathogens was a big deal again, nursing was freaking out and they said, I want an eye wash station in every one of my units. Why? Because somebody might get splashed with body fluids. Eye wash stations are required for caustics and corrosives, right? And are body fluids either of those? No, so call it a first aid station. If it's a first aid station, what's the requirements for testing it? Whatever you decide. If it's an eye wash station, what's the testing requirement? Weekly, right? Aspiranzi C350, 750, 358. And then you got to do the whole, and then the annual on top of that. You got to do all this junk. So limit the number. You do have some eye wash stations. You got one in the power plant. You got one in the lab. You got one maybe in pharmacy, right? So you have some. Maintain those, but all these other ones call them a first aid station. And those little squeeze bottles are not first aid station, are not eye wash stations. Those are irrigation to get me to an eye wash station. And they're always expired, so check the dates on those because they're low-hanging fruit.
Always.
They're always expired. All right. Furnishings, equipment, good repair. Duct tape is not good repair. Clean and free from odors. And it's a cleanliness thing, and this is really high on CMS's list, so it became high on Joint Commission's list. And then critical areas, ventilation, obviously the issues with that, and that can get you in real trouble. Life safety chapter. Piping for approved systems is not to be used to support any other item. Wires on pipe. This is killing thousands of patients in our buildings. but it's number one on their list, you know, so, and that's a wire, you know, it's just a single strand can not be on a sprinkler pipe. Holes and gaps are improperly repaired barriers. Scab patching, right, where I have a hole here, so I take a bigger piece of drywall and I put some mud on there and I screw it in. That's not a repair. What they want you to do is cut it out, put blocking behind it, make it right, do a real repair on it. So, so the days of scabs
I
gone.
got it because it's so funny. When I worked for you back in 2007, 8, 9, somewhere around there, I had several phone call conversations with you about wires on pipes. And here it is, 2025.
I know. And this is where Ashley blew it. I got to say, there you are.
We have that done, folks. The problem is, we're still on the 2012 code.
Yeah, yeah. But it's all you gave us the side contact. I don't care about side contact. I want over the pipe contact. And that's where you guys blew it.
The new language is that it cannot support it.
At all, over or under.
I'll have to look.
You gotta look up this.
But it fixes this issue. If it's, as long as it's not ductwork, as long as it's not a bundle of cables this big.
I asked for give me a baseball-sized bundles, and they wouldn't give me it.
Hey, Jonathan.
Good,
No
okay.
offense, but that's your opinion. Go to the surveyors, and then Barney Fives have a different opinion.
The language in the 2024 code is
All right.
very clear. We worked with NFP.
All right, well, I hope so. You and I'd like to see the language of that, because I want to make sure that it's
I've
right.
heard that same thing you say, and thank you for anybody involved in that.
Yes.
We got to teach these surveyors what support means.
Exactly.
Y'all's the ones who took care of this because you gave us your data of the impact, and we used that to convince and it was the fire marshals. That was a problem.
Yeah, Ken Bush, when I said, give me this, and he said none. Zero tolerance. Anyways, let's go on. Stained ceiling tiles in the life safety code chapter as well. So we have it both in EC chapter and the life safety chapter. Life safety chapter, we're in the egress corridor. In the EC chapter, we're in patient rooms, the soil utility rooms, and those kind of areas. That's why you have ceiling tiles twice, 2 different environments, 2 different impacts. Fire door noncompliance, they don't close. Okay. Sprinklers are not damaged and have escutcheon plates missing, and all that. And I will tell you this. So I will honestly tell you something. So this thing about escutcheon plates and the gap, you know, you get a gap there, and it's like, oh God, you can't have this gap, and because the code says no, you know. And so I had to come up with a reason why, right? So you've heard this thing about, I talk about the smoke migration and all that. That's all BS. So, but I had to have a way to justify it, and everybody sucked it up. Oh, that makes sense. You know, what I would say is I would use the third law of thermodynamics about how heat transfer happens, right? And how, like, if you're doing marshmallows with the grandkids and you have just a coat hanger, how it burns your hands, but if you have a wooden knob on it, it doesn't, and because the heat comes up the thing and burn you. And I said, so in a situation where you have a gap in the ceiling tile from the escutcheon plate missing, that in a fire, the heat is looking for a cooler place to go, right? That's where heat transfer is, and so it's looking for that place, and so when it sees this place here, it'll go up into here, and it will then avoid going to a smoke detector, and so it might lose you like a second and a half because of the way the smoke is, and everybody's, oh yeah, that makes a lot of sense. That is all pure BS, pure fabrication of justification of a code requirement that I have no idea if it's true or not. But everybody bought it for 15 years, so that's right. So that's it, and it got, you know, and everybody's like, oh yeah, that makes sense. So anyways, and ongoing construction without proper signage, that's an ILSM problem. And then the 18-inch below sprinkler heads, you know, it's such a no-brainer, but we still see it everywhere, right? And that's a culture thing as well. So I think I'm right at 9:30, 28. So any questions, anything I hit on? And this will be, I'll send this to Terry, and then you can post it however you want. Questions at all?
I think I got one.
Yeah.
With all of the government departments under a microscope right now, is that affecting CMS and maybe the relationship between Joint Commission and DMV as well?
I hope so.
Yeah.
Yeah, I'd like to see somebody scrutinize some of the requirements that we're forced on.
It's on DPH, just on public health.
Yeah.
Bad, so.
Yeah. So we'll see. I mean,
We had our funding cut out in Georgia from DPH because of it right now.
yeah.
That's correct.
Travel and et cetera. No coalition meeting, no travel, no buying no food.
That's correct.
So if you're state accredited, you're probably not going to get surveyed.
That's a good possibility.
Yeah. So everybody's going to go to state. All right. Any other questions? Yeah.
is it true if you have a work order open, even if it requires a risk assessment for whatever the task may be, that it cannot be cited?
No, that's not true.
Okay.
Yeah, that was back in the days of the PFI, that was true. But they took that day away from us 2016, 15, 16. That was a hard day. But now all it is that's your so they find it, and then your evidence standards compliance is going to be the work order, and then you're fixing it on whatever process you can do. And you can do a survey-related PFI in your response back through your ESC, your evidence and standards compliance, back to the Joint Commission. So you can manage through that good work that you've done, but as far as dodging the bullet, you can't. It doesn't work that way anymore. And that was one of the things CMS said is you can't sidestep a finding. So, yes.
So like when you're doing a fire door inspection, can you have a work order that lists all the assets and that the points that you are checking?
Okay.
Or do you have to have a specific checklist inventory sheet for every door?
I would do managed by exception. I think I would have my PM would say you're checking these 7 different components of a door. And then so I check my door, and if my third door I've checked is the hinges, it's hitting the jamb. So that door I would identify as having a deficiency in that one, and the other 3 they pass the 7 markers. I would just do it by exception, and then track it that way. And then what I would do is be able to show annually or semi-annually that you've evaluated that if this is effective, and it would be. Yeah, it depends. If you have a really robust PM system where you can list them all for each door, that's fine. But that'd be a novel, or it'd be spaced on an iPad. That'd be nuts. So, again, if you have qualified people, they know the 7 things they're looking for. And 7's an arbitrary number I made up. So, okay. Good question. Yeah.
Question. So back to eye washes, I just had this whole conversation. We're fitting to do a renovation at a building. So the way I understand it, it's from chemical dispensing locations
If they're
versus just having it like in a public area.
I'll send you an assessment. It works good.
Okay.
It's gotta be caustic, you gotta mix it. There's no potential to spill.
So just having it like in a public area for just some random something in somebody's eye is not required, correct?
Right.
Okay. I'm glad I was right there.
Okay, send me that assessment too. Send it to everybody.
I'll get it out of
Terry's going to put it on the point. He'll throw it in with my site, and then you got it with that all at one place, one-stop shopping. All right, anybody else? Going once? Yeah.
Just one thing, point and all, talk about the fire doors while ago and how you put them on the workforce system. The way I've always viewed it, from the standpoint, the more assets I've got, the better I can justify my staff within the department. Plus also, I know exactly how many fire doors, so if I have an inspector or a surveyor, I've had them ask, how do you know you've checked all your doors? Well, it's right here. This is all the ones, I got the sheets on the work order. Each work order is an asset. Then I got so many different assets in the building. It actually justifies your people that you have and what's really going on.
Do you do that with your Do you do that with your 500 extinguishers as well?
Yes, sir.
Wow. All right. That reminds me of a consultant that I heard of that was counting numbers of screws missing in door jambs and things like that, and it was like, just nutsy stuff. But again, to your point, if volume is all C-suite to look at, more power to you. But if I was C-suite, I would ask more questions on if I saw an unusually large amount of equipment. But whatever works, it's all about getting our staff right, or getting those numbers back up. And we're not in the 80s anymore where life was good. All right, any other questions before I'm gone? Contact information will be on the slides. Feel free to call me anytime with a question, no charge. Just if you got a question about something, give me a jingle, and I'll hook you up. All right, thank you.